Good afternoon, everyone. My name is Analesa Baraka, and I am an acute care nurse practitioner here today with Dr. Carter, also out of the Boston area, and Shelby from ZERO, here to talk to you today about shared medical decision-making, starting from the screening process to survivorship care. Shared medical decision-making is a very important tool in getting you to talk to providers and accessing healthcare that's relevant to you. So Dr. Carter, I'd like to ask you the first question by asking really, what does shared medical decision-making have to do with screening and prostate cancer?
Well, I think that shared medical decision-making is an important part of the healthcare process, with a man who's coming in for healthcare, coming in to be examined, coming in to be screened for all kinds of cancers, but in particular prostate cancer. And I say that because there's been some controversy around screening for prostate cancer. So you want to make sure that if a patient comes in to see you and he's in the right age group to be screened, that in fact you give him all the information that you can to make a decision about whether he wants to be screened or not. That is, the risk of being screened. If you're going to get a blood test, the blood test may lead to certain processes, certain procedures. You want to make sure that the guy is ready to take those steps. And the way to do that is to make sure he's informed. That means that in some instances, that first visit is not the one where you're going to do the screening. You may have to have a discussion and have the guy go back and read some literature, because there are pitfalls to being screened that have nothing at all to do with being diagnosed with prostate cancer. So I think the important thing is to make sure that you have an educated patient, that he walks out feeling that he's gotten all the information he can about this particular condition that you want to screen him for. And that if he has any questions, he has time to think about it. It doesn't have to be done on the spot. There's no pressure to get it done, but you want him to walk out, if he's at high risk, with some sense of urgency that, this isn't something that you just can't leave to chance, that you want to discuss it with your family, but come back and have another discussion with the clinician to decide whether you want to have something done or not.
Oh, that's really, really great. But how do you handle a patient that thinks that prostate cancer is sort of this, I'll get it when I'm in my 70s or 80s, and I don't have to really worry about that, right?
Yeah.
Why should I get screened?
Well, you have to be real with statistics, and depending on the person and the age group and the ethnicity and the family history, you have to say, well, you have, 1 in 6 chances of developing prostate cancer by the time, you die. And that if you're a certain ethnicity, you may have a more aggressive prostate cancer, and you're more likely to die from that. So you may not be in that group, but you could be. And that's why you want to do the screening. So the key is, why do you want to screen this guy? And why you're trying to get him to be convinced that he needs to be screened. If you give him all the information that he has, and he decides then that he doesn't want to be screened, that's okay, because he's going out as an informed consumer. You've given him all the right information. You feel that you've done all you can. If you push it too hard, it looks like you're promoting what you don't want to promote, because this whole idea about shared decision-making is that this is a patient-centered process, that you got the patient is in the middle. It's him, who's sort of running the ship. You helping to guide it, but he's in charge, and he can say, stop, I want to stop and get off. And that's what happens. So the key is having all the information at hand in a very easy to understand format, so that the patient walks out thinking that he knows as much about prostate cancer screening as you do.
Oh, yeah. So what I'm hearing you say is the patients need to have a conversation and really figure out, is there a family history? So when I come to you, I can let you know that key information, and that can help reinforce should I even get screened or not. Is that correct?
That's correct. That's correct. And another piece to that is that, patients, we need to prep them. That's really the key. The key is that you need decision tools. You need something that has the information in a simple format, because nobody's going to get everything when they sit in that room with a primary care doctor talking about screening for prostate cancer. And you'd be surprised at what patients, well, you would know this, of course, being a clinician, but you'd be surprised at what some patients say went on in a session that didn't go on, or the amount of information that gets missed because they're focused on one part of the conversation and everything else is a blur. So it's important to walk out, if you can do that, with something in your hand that sort of says, this is what prostate cancer is. This is who gets it. What am I in terms of risk? You know, I got that information from the doctor, but I want to see it again. I want to be able to read it, that I'm at X% risk of getting prostate cancer by the time I'm 75. That drives a lot of people to follow up and do some screening that should be done, but it also will allow some guys to say, really, I'm at low risk. I don't need to do this. I'm not going to do it. And I take care of a lot of patients, I take care of a lot of clinicians, a lot of doctors, and many of them will not be screened. They think they're at low risk. They know the numbers. They're knowledgeable, and they refuse to be screened. So I think the key is information. Knowledge, you know, is the best way to prevent bad outcomes with prostate cancer. And I think that that's what we have to do with our patients.
I really agree with that. And I think also just having a commitment to care, right? From both the patient and the provider. From the patient's perspective, men that are educated and they think they're low risk and they've had that informed discussion with a provider and not Google or online is important. And just making time for your own health, right? We've seen people, busy professionals, even people that are just home, busy, like you just can't get into the doctor's office. In my practice too, I've also asked patients to just schedule some time for yourself and schedule yourself into your own calendars and make time for that you know, that screening appointment, that PCP appointment. I mean, before COVID, we had such a backlog and people waiting weeks, if not months, for appointments. And then COVID came and it was easier to put off that screening that you didn't want to go to anyways, right? So now that, you know, we're about to emerge from this pandemic, I think a lot of people have missed screenings and, you know, we have to, you know, can you share your thoughts about how we're going to get our arms around all these people that have missed pivotal screenings?
Well, it's a problem all over the country, certainly in the big academic centers. And, you know, because we canceled thousands of, you know, routine procedures, thousands of colonoscopies, thousands of EGDs, on and on, and all these procedures that normally get done routinely, routine physical examinations put on the back burner. I'm seeing patients now whose last physical was 2.5 years ago because, you know, there was nothing was happening in the practice. People were doing telehealth, but that's fine for talking. You can have great conversations, and telehealth is great if you have something to talk about. But in terms of examinations, feeling things, touching things, evaluating major complaints, the person has to present themselves to you. So we're seeing that backlog now push us in all kinds of ways. People want to do extra sessions. The administration wants to add on, you know, more time because there's more people who want to come in. And I think that lost in that bigger process was a whole bunch of people who had been seen and had bumps in their numbers and that's never had their follow-ups. Had an elevation of the PSA, you know, to 4.5, supposed to come back in 4 months. Now here it is 2 years later and they're coming back and the numbers are 6 or 7. We've had patients who were in the process of being treated for prostate cancer and they got put on hold and their radiation therapy wasn't scheduled because the radiation therapists weren't working and the places were, you know, shut down. So a lot of things went on. If there weren't acute emergencies that didn't get done during the early parts of the pandemic. Fortunately, that's not going on now. We're trying to catch up, but we're still behind. And we have to encourage people to come in and catch up on all those things they didn't do over the past year and a half.
Yeah, and we'll get there, but we also need, you know, your commitment, my commitment, and our patients' commitment to be patient and just get back into the system. So can we just change our focus a little bit and talk about the man that has decided to come in and have his PSA checked and it's elevated and he has an abnormal rectal exam and he's proceeded on to urology for a biopsy and now we've got a definitive diagnosis. Do you see a lot of patients back in your practice after a diagnosis to talk about options?
I see 100% of my patients back. In fact, when I send them to urology, I say, I want you to go and have this done, see the urologist, but I also want you to see the radiation therapist and the medical oncologist, and you come back and we'll have a discussion between you and I about what the next step is. But I want them to come back and not miss anything. I want to know what the radiation therapist said to them. I want to know what the urologist said to them, and in some cases, even the medical oncologist, depending on the situation. But I want to hear what their perception of the consultations are. You see, but that's the key. The key is that you got to know the perception, understand the perception of the patient, because that perception may not be real, but you want to understand that. And if the person says, well, he said this, I said, well, no, I don't think that's what he meant. And reading the note here, it says, dot, 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 dot. It's the wrong perception. So you clear that up right away. Again, that's part of that deal of walking the walk with the patient, that you are on his side, trying to walk the walk, but he's got to make the decision. And clinicians have to be careful about, making decisions for patients, because they'll say, well, gee, doc, what would you do? And you have to sort of turn that around and say, well, it's not what I would do. And you say that in all honesty because values are different. And you're trying to sort of hone this guy in on his own values about how he wants to be treated for his prostate cancer. And that's really key. And again, getting back to shared decision making, all this is sort of patient centered. What's his values? What does he care about? That's really the key.
I agree wholeheartedly with that. And I'm impressed that you can fit people back in your schedule to really, it's a testament to you and the care you provide to bolster this personalized sort of shared medical decision making. And because you know what the specialist had said, because they're sending you a note, but I think assessing what that patient heard is key. And even myself being a nurse practitioner, sometimes you can see when a patient sort of glazes over and the information it's lost. So I'm glad there's someone on the other end like you, assessing to see what really did they hear. Did they only hear I have cancer and it needs to come out? Or did they hear, to Shelby's point, a lot of patients would say, well, I didn't know that this would happen to me. I didn't know about urinary incontinence or sexual dysfunction. This wasn't really explained to me. Or he said it will get better, but I thought that meant days and not months or years. So shared decision making, it's such a simple term that is so heavy. And we have to be careful as providers, as family members, as patients, to really stay focused and centered in coming back to the points. Yes, I have cancer. Does it need to be treated? Yes, it needs to be treated. But what are the side effects I can live with? And have that part of it be sort of that whole patient, whole life approach that will carry you through the survivorship part of this, because that's important. I'm sure that of maybe 20 even more years ago, the sort of culture was, you have cancer, let's take it out and just deal with it. And then you'll deal with whatever else happens. And now in the last 10 years, I think we're seeing a shift where we're now considering this whole health approach. Would you agree with that?
Sure. I mean, I think that if you go back a couple of decades, 20, 25 years, we were using PSAs pretty routinely. A lot of men were diagnosed, of course, who had low-grade disease that never would present itself, and they ended up being treated because they heard the big C word, you got cancer. And it didn't matter to them at the time that it was a Gleason 6 versus a Gleason 10. They didn't know. They just knew they had cancer. And if it's a guy with a spouse and she's saying, well, we got to fix this, you got to get it out, and the family's saying, Dad, you got to get this done. And the poor guy's being pushed and not knowing any better and listening to the specialist, you got cancer, because the views were different 25, 30 years ago. And I think that over time that has changed. And now we know that a lot of these guys don't need treatment and once they're diagnosed. And many of them, with their technologies now that can sort of predict what the potential risks of is you're having bad cancer, even before you get a biopsy. So there are a lot of things now that weren't available a couple of decades ago, and there'll be more things 10 years from now. And I think that the men are in a much better place, which speaks again to the importance of having this discussion. you know. So you got a lot of guys now who won't even be screened. I got professionals who read like I read. They know the literature, and they say, no, I'm not getting this done. You're not going to, you know, I know what the outcome is. But there are many, many instances where the person needs to be treated. If not, they're going to die. I mean, we lose, you know, 20, 30,000 guys a year for prostate cancer. And all of those guys are not 90 years old.
No,
I mean, okay.
they're not.
So you have to keep that in mind, and when you're treating guys and encourage them to be screened. And I start that off with the screening process, and I carry it right through to any kind of treatment options that they've got. And I let them go through all the options. I tell them, I say, okay, this is the risk if you're going to have radiation therapy. This is risk if you have stress. This is risk if you do this. And I said, if there are any side effects associated with any one of these treatment options that you definitely don't want, forget about that option. If there's any potential risk that you're going to have incontinence, and you can say, damn it, I don't want incontinence ever, then don't pick that, because there's a risk. Even if it's small, there's a real risk. And if that's something you would not put up with and you're going to hate it, then avoid it. There was a pretty big report that came out, I don't know, 7, 8 years ago, where they actually looked at satisfaction with the prostate cancer treatment and outcome, the side effects, and the Black men were the most dissatisfied. And so I got to ask, you know, why did I think that was the case? And I knew right away it was the case was that they were treated, but maybe not given all the risks, all the information about potential side effects. You know, you wanted to kill the cancer, but, you know, well, what about the person who's left after the cancer?
Yeah.
And that is that key, that survivorship piece.
Yep. Survivorship is important. Survivorship care, and even, you know, the shared medical decision-making model does not end with just screening and diagnosis. It does really, truly carry out to survivorship care in my practice, and I'm certain yours, because I know your patients never, ever leave your practice. They won't let you retire, Dr. Carter.
No, we're wedded, man, I tell you. But it's important. I mean, the survivorship piece, they come back, and I follow them through, you know, active surveillance and the time when things are changing and it's time really to have some definitive treatment. I do that all the time. And then for the guys who are doing well, you know, I do support group work, of course, but also I follow their PSAs in my practice. I'm the one who does that. And I think from a survivorship standpoint, it's very important for patients with any kind of malignancy to have very close contact with their PCPs about their cancer and understand that they're being treated by the oncologist or by the urologist or whatever, but there's a lot that goes on that maybe that doctor might miss, that clinician might miss. There are long-term side effects of certain radiation that, you know, may not be picked up right away. Cardiac issues that maybe go on with patients who have been treated with radiation that maybe not be picked up right away. And that it's up to the primary provider to pick those things up, to monitor those kind of things, to pick them up. So I do survivorship, and, you know, and have spoken on it, how the importance of it. But I think that's carrying that guy through the whole process.
Oh, great. This is such a very vibrant and interesting topic, because we can talk for hours about it, right? Just when you think you've covered enough, there's something else that comes up. But, you know, in my opinion, and I'd like you to tell me yours, I feel like in this moment with prostate cancer screening, yes, we have a lot of work to do, because people are still dying, right? People are still having adverse outcomes. People are still having low health literacy regarding prostate cancer and PSA and their next options. But the encouraging side is, in the last 10 years, at least, I've been an NP for at least eight of them, right? We de-escalated Gleason 6 disease to active surveillance. We've classified the other more aggressive diseases, and have had some really, really great platforms that came on to help us monitor patients' risk to progress on to more aggressive advanced disease, and advise them to sort of, you know, consider treatment. So I think the outlook is hopeful. Would you agree?
Yeah, well, you know, we've done. I've been involved with a group that has had annual health summits on the Hill for the past 10 or 12 years, and I remember that, and we were pushing, you know, dealing with disparities in prostate cancer outcomes, There was an African-American Prostate Cancer Disparities Summit, and we had those on the Hill, sponsored by the Black Caucus, and there was a big push to get more and more men screened. And a lot of institutions were developing programs to screen in neighborhoods and communities at highest risk for bad outcomes of prostate cancer. The task force recommendations to stop screening after the major studies came out, the European study and of course the PILCO study, made it tougher to do some screening for a while. And so you took a population, the high-risk guys, especially African Americans who were highest risk to begin with, and let them know that they don't have to screen anymore because it's a waste of time. You're totally losing those guys. I mean, they were tough to grab anyway. And now all of a sudden, they're saying, I read it in the paper. I saw it on ABC News that you don't have to screen anymore. So I think that getting around that, which we did, just for people to know that we worked very hard to try to have the task force look at high-risk people differently. And I moderated the conference on the Hill with the chair of the task force, along with a couple other women who were presenting about the risk. And fortunately, we had some changes, at least draft changes in the screening from a D to a C, which meant that, with some discussion with some of these men, there should be a discussion if you're going to screen. And that's important anyway. That should have been done all the time. But at least now that's written into the language of the draft that there should be a discussion. And then after that discussion, the guy can decide whether he wants to be screened or not. So I think that is different than saying, it's a D, that there are harms to screening. Okay, in other words, don't screen because they're harmed, as opposed to after some discussion that, the guy can go on to be screened. They're still not promoting it and not supporting it, but the language is a little bit different. And we played a pivotal role in getting that done. And I'm happy about that. It's going to save some lives, I think.
Yeah, I think it will too. Well, you have been most gracious in agreeing to come on and have this discussion with us today. I want to thank you so much for your time and all of your work in many, many years and passion and dedication to this field. Shelby, is there anything else you think?
Yeah. One of the pieces that you touched on, Dr. Carter, at the very beginning of our discussion, that I've just to echo Analesa's gratitude. Thank you so much. It's been wonderful to just listen in and listen to this great conversation. But you talked about the values and understanding what's important to your patient's values, because those aren't going to be the same values that might be at the top of your list. But it just speaks to the importance of knowing your patients and understanding the differences between each of them. And I wondered if you could, either one of you, maybe touch on the overall mental health piece that goes along with the survivorship. I think especially in prostate cancer, and especially for certain communities, I think we're expanding our outreach to gay men, for instance, and the challenges that those communities face that might be exacerbated a little bit. And we talk a lot about suicide rates in prostate cancer being elevated. So how is it that as practitioners and clinicians, you help guide patients, if it's necessary, to those mental health resources that might exist in communities?
Well, for me, that is one place where families come in to play. It's very important for family. And that's what I meant when I said that the person comes in, but there's a family, there's people associated with them, because they have opinions too. And a lot of times, we're treating that this is a family illness, because it has an impact on other members of the family. For the guys, a lot of many of them are depressed when they first get diagnosed. And many of them will talk about that the first thing that they spent a week in their room and couldn't come out because they had depressed about the diagnosis, not so much the treatment and all that, but just the cancer diagnosis. So as you move through the process, you want to make sure that you get counseling for them. And we encourage that you have a session with the social worker to talk about where you are with this. Sometimes there are major issues, domestic issues with the relationship with the wife and the husband. And even if the wife says everything is okay because you're not functioning the way you used to, the guys don't believe it, or they feel really bad and inadequate about that. And so they need they need somebody to help them along the way. And so we encourage that. I encourage that on all of my patients. And for the gay guys, I mean, we've done screening here. I ran a screening program for Dana-Farber Cancer Center, and we had a community outreach program, and we screened everybody. And we had gay men's group that we would screen, and many of them oftentimes have other issues anyway, so they already got some emotional issues related to to their lifestyles that concern them. And then you bring that on with another cancer diagnosis, it makes it even tougher. So we encourage having a mental health support for all of these men as part of the process of treatment process going along, and not just, when they sort of get very, very ill at the end and now they're really down. You want to work with them as they're going through the treatment process.
Mm-hmm. And I really agree with what Dr. Carter just said. If I may, I just want to give a quick example. So mental health has been like thrusted into the light and almost everything that you touch now, right? We're seeing it in our kids, we're seeing it in the workplace, we're seeing it in normal diagnoses. When you have a cancer diagnosis, yes, there is, like Dr. Carter said, a depression that will happen. But when you take prostate cancer, side effects, right? It's urinary incontinence and sexual dysfunction. It's just so emasculating for a man. When these men that are in their 50s and 60s, even 40s that I have cared for, come in, they're at the prime of their life. They're supposed to be doing really, really big things. And who's thinking about a cancer diagnosis? And it's not a cancer diagnosis that you can just remove the cancer and then you're all set. You move on with your life. Right? So having a mental health plan is important. Having a safety plan is important, and connection to those things, not just a phone number, but a real plan. My synopsis that I would like to share is every time I would work at the BI with my physician that I supported, before I entered any room, I would be like, here's my favorite guy in the whole wide world. And they're all listening to me, okay? So one day, all three of them came out of the room. I thought I was your favorite guy in the whole wide world. So they're like, I knew you were pulling my leg all along. So it comes back full circle, and it comes back to finding providers that identify with you and that you can identify with. It's about getting both of our arms around this patient population and saying, you know what, you have a cancer diagnosis, but it doesn't make you less of a man because you don't have an erection. And we have to change the narrative around that. And you can have an erection. It depends on how motivated you are. There are pills. Everybody knows that little blue pill. Everybody knows about injections. And then at the last line, it's a penile prosthesis. But we really need to, as a medical community and just as people and just being human to each other, how are you doing today? I know you had a cancer diagnosis. You want to grab a cup of tea? Pair that man with a peer-to-peer support so they can talk to each other about their experiences. That I feel is the most powerful, lasting, valuable interaction for them, because they compare themselves. They talk about, okay, well, I started to get some erectile function back maybe at 1.5 years, but you have to ask your doctor, was it nerve sparing? Was it not? Or even have this discussion with your provider. That's where it starts. And for people, I mean, there is a segment of people that are truly alone out there, and you're their only lifeline. But encourage people to bring their partners, bring their, whoever they trust to be a health advocate for them. It's just a support system that's invaluable. And I am happy we're having this discussion about not just heterosexual men, but also transgender people and gay men, right? Because we have to really beef up the care we provide when it comes to dealing with this population. And reinforcing it is not emasculating. It is a process, and you are supported. And we need to hold a line for each other and be better at it.
Agreed.
So yes, they're all my favorite guys in the whole wide world. I swear I'll take them all with me wherever I go. But I mean it when I say it.
Yeah, and I think you both just speak to the trust that is so imperative between a patient and their providers, because if a patient doesn't trust their providers, they will not open up and share the side effects that they're experiencing. And we know, because we deal with this every day, that by sharing those side effects that you're experiencing, the sooner the better. We can help find solutions for so many of those. We have a great talk as a part of our summit. It'll air on Friday of our Zero Prostate Cancer Summit by Dr. Rachel Rubin. So she really will take a deep dive into the physiological issues that go into some of the sexual side effects. And it's really fascinating. And I think you learn so much by understanding it's not just, I can't get an erection, that's the end of the story. It's the why and the how and the different things that go into it. And all of these things, like I said, on the physiological level that are involved in sexual health. So it just so important to find a provider that you trust and that you can share your side effects and your journey with, so that you can be better supported. So thank you both so much for letting me kind of ping some questions to you and weigh in a little bit.
Real pleasure. Thank you.
Thank you both.
Thank you.